So in week 3, we're going to study the drugs that affect the central nervous system and the peripheral nervous system. And, chapter 19 is an introduction to nerves and nervous system. I'm not going to tell you, you need to review that, I guess. Unless you don't think you need to review it, then don't. Don't spend any time going over material that you already know. If you don't know it, then you need to take at least a cursory review of the very system that these drugs affect. Chapters 20 and 21 are on anxiolytic and hypnotic agents and antidepressant agents. Anxiolytic, cutting, anxiety. So those are anti-anxiety drugs, hypnotic drugs, antidepressants. For sedatives, I want you to pay attention to the class of benzodiazepines. We call them benzos, but they're an important part of what we call procedural sedation or conscious sedation. We usually give one pain medication, one benzo medication, a relaxant medication. Specific drugs I want you to focus on in that class are Valium, probably familiar with it, and Versed or midazolam, Ativan, and Xanax. So just take a look at those drugs in particular. Also, when we're talking about drugs like this, is there a reversal agent for the benzos? There is. It is romazicon or flumazenil, same thing. And that is considered a reversal drug for the benzos. So read about how that works. And then when it comes to patient teaching for a patient on any of these drugs, one thing that should come to your mind in your patient teaching is that this patient is going to be a fall risk because their senses and their reflexes can be affected. In this category also we have sleeping pills, muscle relaxers, and barbiturates. Over the years we've kind of determined that barbiturates can be problematic, in some cases more trouble than they're worth. In the sleeping pill category, take a look at Ambien and Restoril. In the muscle relaxant category, take a look at Baclofen, B-A-C-L-O-F-E-N, Baclofen, and Flexeril. And in the barbiturate category, take a look at phenobarbital. Barbiturates have high degree of adverse reactions and a low therapeutic index. So you're taking a great risk for very little benefit. So the barbiturates as a category are not as popular, as I say. Chapter 21 deals with antidepressant agents. The new generation antidepressants are the SSRIs. You should know what that stands for. And how do the SSRIs work? And why are they so popular? And why are they considered safer than the old generation? And those would be the Prozac, the SSRIs, Prozac, Zoloft, Wellbutrin, etc., versus the old generation, the tricyclics, antidepressant agents. What are our nursing considerations for that category? What are our patient teaching tips for that category of drugs? Chapter 22, the psychotherapeutic drugs. Interesting chapter, reminds us about mental illness and chemical imbalance, the relationship there. We do use benzos for these patients as well, the benzodiazepines for anxiety, for ETOH withdrawal, and sometimes for seizures. Lithium is an important drug in this chapter. It's considered a mood stabilizer. Antidepressants are considered psychotherapeutic. Antipsychotics like phenothiazines, Haldol, clozapine, and Risperdal, R-E-S-P-E-R-D-A-L, Risperdal. Sometimes we see an adverse reaction called a paradoxical reaction. When you give the drug for one desired effect, what occurs is just the opposite, a paradoxical reaction, and that can happen with some of these psychotherapeutic drugs. There is a huge table in this chapter that talks about drug-drug interactions and drug-food interactions. And we do want to be careful about multiple prescribers for patients who are on these kinds of medications. You do not need to go to a psychiatrist to get an antidepressant. Any nurse practitioner, family physician, internist can and do prescribe antidepressants. Some of them do shy away from these more psychotherapeutic drugs because they understand the reaction potential for these drugs. So it is probably prudent to have doctors who specialize, like psychiatrists, specialize in care of patients like this to prescribe those kinds of drugs. Chapter 23 is your anti-seizure agents. These are the anticonvulsants. There's an overview of seizure disorders and therapeutic plasma levels, which is how we determine if a patient is taking too much or too little of their anti-seizure med. In this category, we have phenobarbital, Dilantin, Cerebyx, 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 Tegretol, Depakote, Neurontin, Keppra, and Topamax. Those are all considered drugs in this anti-seizure category. There are tons of interactions with anti-seizure meds. Lots of patient teaching to pay attention to. And then some other uses for instance, Neurontin and Lyrica. We also see use for restless leg syndrome, and that would involve the periphery versus the central nervous system. That's for peripheral neuropathy, sometimes fibromyalgia. So there's a little crossover between the central and the peripheral nervous system. Chapter 24 is your anti-Parkinsonian medications. Parkinson's disease, there's an overview of Parkinson's. That's a complicated disorder, but basically you have insufficient dopamine. It affects 1 million Americans. There's other CNS disorders that are addressed in this chapter too, because they sometimes benefit from the same medications, like myasthenia gravis, dementia, and Alzheimer's are to mention a few. So some of the medications that we give for Parkinson's are Sinemet, S-I-N-E-M-E-T, Sinemet. We give carbidopa-levodopa. There's an adjunctive treatment which is given in conjunction with these other medications called, I'll spell it for you because it's difficult for me to even pronounce. It's Selegiline. Selegiline? That's probably incorrect. In this chapter, you'll read about MAOIs, which is monoamine oxidase inhibitors. There are tons of reactions that occur with MAOIs. So the prescription of those medications, I would say, is on the lower end, simply because sometimes there are so many side effects and so many inadvertent adverse reactions that can occur. Sometimes the drug is more trouble than the benefit of it. So we talked about dopamine. Insufficient dopamine is the root of Parkinson's. We consider dopamine is a neurotransmitter inhibitor, and acetylcholine is the neurotransmitter exciter. So when you have insufficient dopamine, the inhibitor, you're going to have an adverse abundance of the exciter, and because that's what you're left with. All you're left with is the exciter. So Parkinson's meds must be given on a schedule. There can be no late doses, no skip doses. So if you're ever taking care of a patient in a hospital with Parkinson's, they might get medications 6 times a day. And sometimes nurses don't appreciate, like, why can't I just bunch these up and give them all at one time? This is to maintain that balance between the inhibitor and the exciter, that these medications don't have a long half-life, so we have to be giving them continuously on a strict schedule in order to keep the blood levels therapeutic for the patient, in order for them not to have the symptoms of Parkinson's. Another word I want you to pick up from this chapter is extrapyramidal effects. Extrapyramidal effects in this chapter we'll talk about anti-Parkinson meds, but you can also get extrapyramidal side effects from any of your psychotherapeutic drugs as well. Chapter 25 is muscle relaxants, and I think I already mentioned muscle relaxants. I know I mentioned baclofen and Flexeril. Chapter 26, narcotics, narcotic antagonists, and anti-migraine agents. Basically, analgesia. You're going to know by the time you're done here, you're going to, of course, know the difference between analgesia and anesthesia. For pain management, narcotics is our mainstay, and the importance of assessing the patient for pain, the administration of pain meds. This is a primary nursing responsibility. And we look to the nurse to be the advocate for the patient who is in pain and receiving pain meds. When we talk about the nursing process, we now look at an assessment. Besides vital signs, we now look at pain as the fifth vital sign. So you've got your patient's blood pressure, heart rate, respirations, temperature, etc. And what is your pain level as the fifth vital sign? The book will tell you about using a 1 to 10 scale, and I'm sure you're familiar with that. The required documentation when a pain medication is administered in the hospital. Analgesics, we use opioids equals narcotics, and then adjuvants, which are other categories of medications that are used in conjunction with narcotics to potentiate the effectiveness of that medication. We talk about terms like opiate naive and opiate tolerant. Opiate naive would be someone who is simply not used to taking narcotics. They don't take them at home, they don't take them for chronic pain, and so we give them in the hospital with concern that we want to watch the patient who is not used to this kind of medication. And then we have the opioid tolerant patient who may need a lot more medication than we believe. Again, this is just a reminder, I think your text will bring it up, but when it comes to pain, pain is considered subjective. We, as a nurse or a provider, do not determine the patient's level of pain. That is for the patient to tell us. And I have to remind even students that when we have a patient on a med-surg floor, or a patient recovering from surgery, the patient is not, unless we're working in a drug rehab unit, we're not there to rehab the patient or to wean them off of their pain medication. We are there to provide them a pain-free experience as they recover from whatever it is they're in the hospital for. And so that's kind of a paradigm shift for a lot of people who have preconceived notions about people and stereotypes and pain, drug abuse or drug seekers or whatever. It's actually a burden that's lifted off the shoulders of nurses when they're in the hospital. That's not our game plan. We're here to give you a good time so that you're pain-free. The medications in this category are morphine, morphine sulfate, hydromorphone, which we know is Dilaudid, fentanyl, oxycodone, hydrocodone, and of course we have the reversal drug for narcotics, Narcan. And acetaminophen is also in this drug. Your book may talk about it as an antipyretic. Acetaminophen is not really considered, and it doesn't really have a significant antipyretic reducing fever effect, but it is effective on mild to moderate pain relief. So you see in the hospital, LPNs, you're probably aware of this, well, depending on if you work in an acute care setting or not, you may not be. Paramedics, you're not going to be familiar with the idea of pain management as customer service. But once you get in the hospital, you will get to know that, you know, the hospital and the providers are scored by the patients. And there are many questions that they're asked in their questionnaire and that pertain to their pain, their management of the pain. Was the doctor sensitive to my pain? Was the nurse sensitive to my pain? How long did I have to wait before my pain medication was delivered, etc.? So there's a huge, big emphasis on keeping our patients pain-free. So we'll also look at the adverse reactions of narcotics. which pain is best served by which medication. Is it a narcotic, or could it be an NSAID, a nonsteroidal anti-inflammatory, like Toradol, ketorolac, is a great example of an NSAID that can be used in place of a narcotic. Now, NSAIDs we'll talk about later, they have their own barrel full of complications, but the typical complications that we associate with narcotics, which are respiratory depression and GI slowing, significant GI slowing, so that when we're giving our patients narcotics over the day, a day or two, we need to be giving them, for instance, stool softeners as well, so that we're not creating a different kind of a problem. But Toradol does not cause GI slowing. Toradol does not cause respiratory depression. It does cause some other very serious things if it's used too long. Toradol is safely used in a hospital environment 3 to 4 days max, then it's discontinued. IV acetaminophen, I mentioned. The idea of PCA pumps, patient-controlled analgesia, where the patient dispenses their pain medication when they feel that they need it. Nursing considerations for PCA pumps include the pulse oximeter, continuous pulse oximeter, and we need to have, even for a patient with PCA, we need to have orders for what's called breakthrough pain. How do we address that pain that rises up in between dosage periods where it's not legal for us to give that original narcotic again? This is a very interesting chapter. So is the one on psych meds, but the one on narcotics and pain medications I think is very interesting. Then chapters 27 and 28 go on to address anesthesia. The big term today is balanced anesthesia, and that is the anesthesiologist's secret recipe of balancing gases and nerve blockers and narcotics and benzodiazepines, a little of this and a little of that to provide you a balanced anesthesia experience. They're using the least amount of medication to provide the most amount of anesthesia for you. There's not a lot of drugs in these chapters for you to look at because, truthfully, nurses don't have any business with a lot of these drugs. In some cases, like when you're talking about intubation, possibly. But for instance, in Arizona, it is not legal for nurses to hang propofol. That is the job of the anesthesiologist. The exception would be for a patient that's fully vented in an ICU setting and perhaps the infusion is initiated by an anesthesiologist or an intensivist and then it's maintained by the nurse. If propofol is used in conscious sedation or procedural sedation, the nurse is not to be giving it. You can draw it up and you can pass that syringe over to the physician because it's not in your scope of practice to be giving propofol. Lidocaine or bupivacaine are considered locals. You'll read about neuroblocking agents for skeletal muscle. Well, you know about the paramedics, you know about vecuronium and succinylcholine, Vec and Sux. Spinal anesthesia is very popular. Intrathecal, that is when the needle goes into the subarachnoid space of the spine when general is too risky or not desired. Epidural anesthesia, when the catheter goes into the epidural space without ever puncturing the dura. And then there's no loss of consciousness, but rather numbing. Read about spinal headache as a result of epidural or spinals. That's about it. That's my advice for Smart Read of these chapters. You'll have a week 3 quiz, which will be on this material that I just talked about. And again, you had about 10 chapters, so there'll be 1 or 2 questions from each chapter. It's likely to be something that you'll either find in those important summary key points or something I mentioned here in the video. Now, don't forget week 3, you also have a VSIM to do. You have VSIM scenario number 7. It's on patient Jermaine Jones. If you didn't do a practice VSIM yet, Know that you can do any of them. You'll see them lined up under the vSIMS tab on your Lippincott site. If you haven't done the vSIMS tutorial, do that before you do scenario number 7. And know that you can repeat it multiple times, but I'm looking for a score of 80 in order to give you full point. So that is due this week as well. So this is a heavy week. I wish you good luck and let me know if you have any questions. Thanks.